Welcome to Essential Neurologic Exam. I am David Lee Gordon, Professor of Neurology. I would like to thank the many people who assisted me in developing this program, especially the neurologists who first helped me develop the contents and format of the Essential Neurologic Exam, Jafar Khan of Emory University, Stephen Lewis of Lehigh Valley, and Patrick Reynolds of Wake Forest. In addition, the team that helped me create the videos in this presentation, Evan Fields, who played the patient, Olivia Nicole Gordon, who was the videographer, and Adria S. Chappell, who was substitute videographer. And the team that helped edit this presentation was Adria Chappell again and Stephen Clayton. The learning objective for this presentation is as follows. After viewing this presentation and practicing the Essential Neurologic Exam with feedback from an instructor, the learner should be able to perform an Essential Neurologic Exam in less than 10 minutes on a patient without neurologic disease using proper technique and, if necessary, a pocket card as a prompt. One should tailor the neurologic exam to the patient and situation. The Essential Neurologic Exam covered in this presentation is to be performed on all patients with suspected neurologic disease, including new patients in the hospital and clinic. There are 46 items. It should take about 6 to 10 minutes, and there are 6 different tools. Focused neurologic exams are when one performs select items in addition to the essential exam based on history and essential exam findings in all patients with suspected neurologic disease. There are symptom, sign, or condition-specific neuroexam items that are called focused neurologic exams. The screening neurologic exam is to be performed as part of a general physician exam on all patients without suspected neurologic disease and all return neurologic patients with previously normal essential exam. This is a quick neuro exam consisting of essential exam components. There are only 15 items. It takes only 2.5 minutes, and there are no tools. The pocket card to accompany this presentation has 3 different sections. Screening neurologic exam and essential neurologic exam are on the front, and the various focused neurologic exams are on the back. This presentation, we will emphasize only the components under essential neurologic exam. This is an enlarged view of the essential neurologic exam components, the core exam for all neurologic patients. Once again, there are 46 items. It takes 6 to 10 minutes, and the 6 tools needed are a pen light, ophthalmoscope, Rosenbaum card, safety pin, tuning fork, and reflex hammer. The tools needed to perform the essential neurologic exam include a pen light and ophthalmoscope, although one may use an ophthalmoscope or the light of a sanitized phone as a pen light. The Rosenbaum card, the pocket card for assessing visual acuity, a safety pin. Size 2 pins are optimal. Realize that size 0 is too small, and only use 1 pin per patient. Always discard the pin after using it on that patient. A tuning fork, specifically the larger 128 Hz tuning fork. Do not use the smaller 256 Hz tuning fork. The rationale for this is explained later in the presentation. And a reflex hammer, and only use a hammer with a heavy head or long handle. 3 good examples are the Tromner hammer, Babinski hammer, and Queen square hammer. The emphasis when using essential neurologic exam is simplicity and efficiency. The essential neurologic exam includes core or essential items for all providers, neurologists and non-neurologists, novices and experts. The essential neurologic exam avoids impractical, unuseful, and redundant items, and for example does not include the mini mental status exam, MMSE, does not include the MoCA, Montreal Cognitive Assessment, because those are felt to be impractical for generalists. It does not involve or include complete language testing, smell, accommodation, cardinal positions of gaze, Weber, Rene, wrist flexors, all of which are rarely useful in asymptomatic patients. Might be done in patients with other symptoms, but not in the asymptomatic patient. It does not include grip. Grip is not useful due to poor intra and interrelator reliability. And it does not include multiple methods for assessing limb ataxia and plantar testing. This is redundant and confusing to non-neurologists when teaching multiple ways to do the same thing. The essential neurologic exam emphasizes simplified, standardized techniques for both ease of learning and time efficiency, and includes only one way to perform each item. Focused neurologic exams should be performed in addition to essential exam as indicated. They are very important, but are not included as part of the core essential neurologic exam. Some additional exam aids include an optokinetic nystagmus tape, red lens, 2 identical red targets, tropicamide 1% solution, NIH stroke scale cards, and the aids to the examination of the peripheral nervous system. An excellent book that helps with examining the peripheral nervous system. The screening neurologic exam is a very brief exam to be performed as part of a general physical exam and is not included in this presentation. Please note that in order to improve time efficiency in the screening neurologic exam, we've moved 2 items, eliminating cranial nerves category and instead having mental status, eyes, sensation, motor coordination upper, motor coordination lower, and gain station categories. The main categories or outline of the essential neurologic exam are mental status, cranial nerves, motor, sensation, reflexes, coordination, and gait and station.
Hello, I'm David Lee Gordon, Professor of Neurology. When performing the essential neurologic exam, start with level of consciousness. First, assess is the patient awake, alert, and attentive. Hello, sir. How are you today?
Doing well.
You can see he is awake, alert, and attentive. Decreased consciousness can be described in different ways. The best way is to use regular language, not medical language. Simply say, what is a stimulus that aroused the patient? Awake and alert and attentive is normal. If he were slightly drowsy or sleepy, we might say he has eyes closed, aroused to verbal or stimuli, or aroused to tactile stimuli. Or do you need painful stimuli to arouse? Or does he not arouse at all? So these are the kind of ways you describe level of consciousness. They are divided by some into drowsy or lethargy, which is about the same thing, stupor or coma, but it's best to use just regular language and describe specifically what stimulus aroused the patient.
Tips and pearls for mental status, level of consciousness. Start the neurologic exam by always observing the patient's consciousness. Describe the normal consciousness as awake, alert, and attentive to the examiner. Describe depressed consciousness in terms of the stimulus needed to arouse. For example, aroused to verbal stimuli or voice, aroused to tactile stimuli or touch, aroused to painful stimuli or pinprick, or aroused to only deep painful stimuli such as sternal rub. Coma means no meaningful response to deep painful stimuli. Decreased consciousness is due to inhibition of the ascending reticular activating system or ARAS via either bicerebral dysfunction or brainstem dysfunction.
Let's now test language. Now there are 4 components to language testing, but in the essential neurologic exam, we're only going to test one of those components. That's naming, because naming is abnormal in all language dysfunction, all aphasias. And try to use things that are really well known to the patient so that you don't pick dialect or other terms they may not know. The simple thing is using the hand. And start with the big component and go down to the small component, because it's easier to name a large thing and harder to name a small thing. So here's an example. What is this thing, sir?
It's your hand.
And what is that?
Finger.
And what is that part right there called?
Fingernail.
Hand, finger, and nail. The easiest things to use for language testing.
Tips and pearls for mental status, language, naming. Perform language testing after consciousness assessment and always before orientation or any other mental status testing, because incorrect responses on further mental status testing may be due to language difficulty, not true confusion. If naming is abnormal, then complete the language testing by also assessing comprehension, repetition, and fluency. Language dysfunction is called aphasia and occurs with dysfunction of the dominant cerebral hemisphere, which is the left hemisphere in most people.
Only after you have assessed level of consciousness and naming can you then proceed to the rest of the mental status testing. And on the essential neurologic exam, we're only going to do orientation after we've done after level of consciousness assessment and naming. Okay, sir. Tell me, what's your name?
Evan Fields,
And where are you right now?
Oklahoma City at the OU Medical Center.
Good. And what's the date today?
It's March 26, 2021.
Good. You got all three right. We just asked those three things: name, location, and date. Now, if people don't know the exact date because they're not looking at their phone or their watch or something else, then that's okay, as long as they're near the right date. They can say beginning of the month, middle, end of the month. They should know the month for sure, and they should know the year for sure.
Tips and pearls for mental status orientation. Only assess orientation after assessing naming. Assess orientation to person, place, and time. Recalling the exact date is sometimes difficult for patients with normal mental status, so accept the year, month, and beginning, middle, or end of the month. Disorientation with normal language function usually occurs in a setting of true confusion due to delirium or dementia as a result of bicerebral dysfunction. The inability to name one's self, apparent disorientation to person, only occurs in patients with aphasia or profound dementia and does not occur with isolated amnesia.
After mental status testing, proceed to the cranial nerves. And we'll start with fundoscopy. For fundoscopy and pupillary light response, you must turn off the lights, but have an ambient light on so that you can see what's going on. So the key to a fundoscopic exam is to make yourself comfortable and have the patient look in a direction that is comfortable for you when you look in, first of all. Second of all, you must have the patient look in the far distance in order to maximally dilate the eyes prior to doing the fundoscopic exam. Sir, look in the far distance at the top of that ceiling there. Thank you so much. And you want to curve in. You want to first look in the back of the eye. You're looking for the red reflex, And I can see it. That means that you can see the retinal arteries, basically. And I'm going to curve in. I'm going to see arteries. And then I follow the arteries to the disc. Now I have to do the other side. To the other side, I have to go to the other side of the patient and use the other eye. You have to use your left eye for the patient's left eye and your right eye for the patient's right eye. Sir, look in the distance up there. There you go. Fundoscopy.
Tips and pearls for cranial nerves fundoscopy. In order to dilate pupils as much as possible, always turn the main room lights off. For ambient light to facilitate your vision, either crack the door open or turn on a dim light. Have the patient look in the distance and do not block the patient's vision in the contralateral eye. Ask the patient to modify head position and gaze direction at an angle that facilitates your comfort and ability to visualize the fundus. Right for right, left for left. Always use your right eye to examine the patient's right eye and your left eye to examine the patient's left eye. Follow the retinal arteries to their origin at the optic disc. Don't first look for the optic disc. Look for the retinal artery and then follow it in to the hub to the optic disc. Stand lateral to the patient with your offhand on the patient's shoulder. Ensure the light shines on the pupil. Visualize the red reflex and retinal arteries through the ophthalmoscope. Then arc in towards the patient, keeping the light on the fundus and following the arteries to the disc.
Now let's proceed to visual acuity. Now we're testing visual acuity as neurologists, not as ophthalmologists and not as optometrists. So the actual visual acuity of the patient is not as important as recent changes in visual acuity. So what we use is a Rosenbaum card, which is a miniaturization of the Snellen card. And it says at the bottom, hold the card 14 inches away. That's not really true for neurology. It doesn't matter where you hold it. It matters, only thing that matters is that at a good distance for the patient's comfort. And you must always start by asking if the patient wears glasses. Because again, we care only about changes in visual acuity. So we care to ask, we want the patient to wear glasses during visual acuity testing. Do you wear glasses, sir? No, he does not, so we can test without it. The next thing we do is say, sir, cover one eye with your palm, cupping it without mashing the eye, and curve it a little bit so you can't see, good. And hold this at a distance that's good for you. Good for you. Okay? Now I want you to read the lowest possible line of numbers on the left here that you can.
3, 7, 4, 2, 5, 8.
Okay, is that the lowest you can?
9, 3, 7, 8, 2, 5.
Excellent. Many times people get insecure and actually give you a number higher, a layer higher than they can actually name, so you need to actually test them and push them. Let's see the other eye, sir. Lowest one you can.
9, 3, 7, 8, 2, 5.
Excellent. Thank you so much.
Tips and pearls for cranial nerves visual acuity. Always test visual acuity with reading glasses on. First, ask if the patient wears glasses and advise wearing them for the testing. Neurologists assess non-refractory visual changes. Ask the patient to hold the card at a comfortable distance. Ignore instructions on the card that say to hold the card 14 inches away. Ask the patient to cover one eye gently, cupping to avoid compressing the eye and slant it along the nose to avoid peaking. Test one eye at a time. Push the patient to read the lowest line possible. And visual acuity changes are often due to optic nerve or cranial nerve 2 dysfunction.
Now let's test visual fields. Now, visual fields is actually one of the easiest things to test for a neurologist and somehow one of the hardest things to test for non-neurologists. So let's understand what we're doing here. The patient's visual fields are like an ice cream cone. They come out like this, and then there's a curve to them. It actually is nonsensical to test visual fields too far out. All you care about is identifying problems in the four quadrants in each individual eye, okay? And because there's a curve to the top, if you go out too close, the patient doesn't see these at all, and he may not see them unless you curve the hands. So it's easier to forget all that and just stay farther back and stay flat, and you want to be just below your chin and just above your eyebrows, okay? Okay, and only have the patient count fingers 1, 2, and 5. Normal people sometimes cannot distinguish fingers 3 and 4, so don't use fingers 3 and 4. 1, 2, and 5. Okay, so again, cup your left eye for me. There you go, perfectly. Make sure you can't sneak a peek in the side there. Look at my nose, and how many fingers do you see?
2, 5.
Good. Look at my nose. How many fingers do you see?
1, 5.
Good. Now the other eye. Look at my nose. How many fingers?
5, 2, 1, 5.
Good.
Tips and pearls, cranial nerves, visual fields. Do not cover your own eye when performing visual field testing. It may confuse you and is not necessary. Note that each eye's visual field is shaped like an ice cream cone. Use only 1, 2, or 5 fingers when assessing finger counting. Do not use 3 or 4 fingers. Do not stand too close to the patient. Ask the patient to cover one eye gently, cupping to avoid compressing the eye and slant it along the nose to avoid peaking. Though realize in patients with known brain disease, you can also perform both eyes open at the same time. Monocular visual field deficits are usually due to retinal disease. Homonymous visual field deficits are due to contralateral posterior brain lesions, temporal, parietal, or occipital lobes. Note the cartoon on this slide. Keep the 4 quadrants in tight, close to the midline, with your hands flat to the patient and your fingers either just above your eyebrows or just below your chin.
Now we're going to test pupil light response. And just like with fundoscopy, one must turn the lights off and have the patient look in the far distance. Okay, sir, look in the far distance up on the ceiling, and you want to come in from the side so you don't block his vision. You don't want his pupils to constrict on something he's seeing. You want to have them be dilated before you put the light in the eye. I'm going to test the right eye first and look at the direct response. In other words, the right eye's pupil. It constricts, see that? But now you want to go a second time to see the indirect response. So now that means the left eye. Look at the left eye when I put light in the right eye. It also constricts, direct and indirect. Let's do the left eye. Come from the side again, and you see the direct response. The left eye, the pupil constricts. But when I go back a second time looking at the right eye, I see the right pupil also constricts. Direct and indirect pupillary response to light.
Tips and pearls, cranial nerves, pupil light response. In order to dilate pupils as much as possible when testing them, turn the main room lights off. For ambient light, to facilitate your vision, either crack the door open or turn on a dim light. Have the patient look in the distance and do not block the patient's vision. Stand to the side of the patient. Use a pen light or ophthalmoscope or light from a sanitized phone. Shine the light into the pupil from the side. Check each eye twice, assessing both the direct and the consensual responses. The direct response is the eye looking at the light. The consensual response, also known as the indirect response, is the opposite eye. Afferent defects, which are often due to optic nerve dysfunction, or efferent defects, which are due to a weak iris sphincter muscle due to dysfunction of the parasympathetic component of oculomotor nerve, may cause abnormal pupil response to light. Note that we do not assess pupil response to accommodation or near vision in the essential neurologic exam.
Now let's assess extraocular movements. And for the purposes of the essential neurologic exam, we just wanted to look at a cross, all the way to the left, all the way to the right, up and down. And I think the best way to do this is to put your fingers on his chin as a subliminal message not to move his head. Otherwise, the patient moves the head around, and you want them only to move the eyes. So, sir, look at my finger. Look at primary gaze first. Okay, sir, don't move your head, just your eyes, and follow my finger all the way. And you want to make it go all the way out so that he buries his sclera. The white part goes away. And then go all the way to the other side, and you see that he buries his sclera on the right. Now, you're going to go back to the middle, check primary gaze, check up gaze all the way, then down gaze. And sometimes you need to lift the eyelids so you can see properly. Now, it's very important to realize that in the essential neurologic exam, we're looking at only the cross. But if somebody has double vision, if their symptom is diplopia, double vision, then you must do more than the cross. You do the cross, and you also go into the corners, the so-called H. Okay? That is, however, only important if the patient has symptoms of double vision, diplopia. If they don't have those symptoms, then it's best in the essential exam just to do the cross.
Tips and pearls, cranial nerves, extraocular movements. First, observe the patient's eyes in primary gaze, that is to say, the patient looking straight ahead. Then, check the four main directions of gaze: up, down, left, and right in a cross, touching the patient's chin while you do this to ensure the patient does not move. Only check the cardinal positions of gaze, the H, if a patient complains of double vision or diplopia. Bury the sclera, the white part of the eyes, in all directions when performing extraocular movement assessment. Ensure the eyes move completely in all directions of gaze. If the patient is below you, lift the eyelids to visualize the patient's down gaze. Disconjugate gaze, when the eyes are misaligned, and resultant diplopia are due to extraocular muscle weakness, and this is often, but not always, due to cranial nerve 3, 4, or 6 dysfunction.
Now let's assess facial sensation. And there are two components to facial sensation: light touch and pinprick, first of all. Second of all, you want to test in three specific areas, and you want to stay relatively medial. So the forehead medially, over the cheeks, and over the chin medially. If you go too far out, you're not in the trigeminal nerve dermatome. Let's start with light touch. Now, when you're assessing light touch, you want to have a very light brush with your fingers. Very light brush. You don't want to tap. Tapping is not good. That stimulates sensory fibers underneath the skin, and you only test the skin. So, sir, and you have the patient close her eyes. Close your eyes, sir, and tell me, with light touch, you need to ask where I'm touching. Sir, where am I touching you?
Left forehead.
Now where am I touching you?
Right forehead.
Is it the same on both sides?
Yes.
Every time you test sensation, you must ask, is it the same in a perceived normal area to a perceived abnormal area? And since most patients who come to a neurologist might have brain problems, we're mainly looking at left versus right, okay? Keep your eyes closed, sir. Where am I touching you?
Left cheek.
Now?
Right cheek.
Is that the same on both sides?
Yes.
Excellent.
Left chin. Right chin.
Same both sides?
Yes.
Okay, now we're going to do a pin and test sharp pin. Sorry, this is a sharp pin. I'm going to poke you. Do not test on yourself first. That would contaminate the pin. You're going to use a safety pin. Only use a safety pin. Don't use a needle, anything else that breaks the skin. And I don't like using sticks either, because people sometimes use those Q-tips, those sticks, and unfortunately, after using it twice, they are not sharp anymore. So use a safety pin, but throw it away after you're done testing the patient. Use only one pin per patient. And so this is how I do it to get the patient ready. Sir, close your eyes and tell me if it's sharp or dull. And in this case, you're not saying where. You don't ask where with a pin. You just say, is it sharp or dull? Is it sharp or dull?
Dull.
I always start with the dull just to kind of get the patient ready. Now, is it sharp or dull?
Sharp. Sharp.
Is that the same on both sides?
Yes.
Sharp or dull?
Sharp.
Sharp or dull?
Sharp.
Same both sides?
Yes.
Sharp or dull?
Sharp. Sharp.
Sharp or, is that the same on both sides?
Yes.
Excellent. Facial sensation.
Tips and pearls, cranial nerves, facial sensation. All sensory testing involves comparing two different areas. For example, right versus left or distal versus proximal. In the essential neurologic exam, after similar stimuli on each side, always ask, same both sides? When testing light touch, lightly stroke the skin. Do not tap the skin. Lightly stroke it. Ask, where do you feel it? When testing pinprick, using your wrist, tap twice firmly. Ask, is it sharp or dull? For facial sensation, test on either side of the midline in each of the three trigeminal nerve dermatomes. V1, the forehead, V2, the cheeks, and V3, the chin.
Now let's assess facial strength. And so we're looking for three areas mainly: the forehead wrinkling, the widening of the palpebral fissures, where the eyes are, and the nasolabial fold. You want to see symmetry. So you look at the patient, and he has normal symmetry. The eyes are open about the same amount. The forehead, the mouth, all looks good. Now, you first say, sir, raise your eyebrows as high as you can. And you see the wrinkling on both sides is equal. Excellent. Then you say, close your eyes as tight as you can, sir. And you want to close them tight, and you want to say, don't let me open them. And I can't open them. He's got strong eye closure. Then you say, sir, smile for me. And you can see the nasolabial fold on each side increases equally on both sides and goes up at the same time. If one side were weak, then maybe one side would go up faster than the other each time, or it wouldn't go up at all. That would be a facial weakness.
Tips and pearls, cranial nerves, facial strength. First, observe palpebral fissures and nasolabial folds for asymmetry while the patient is at rest and during conversation. Then ask the patient to smile, raise the eyebrows, and close the eyes tightly. You are looking at the frontalis muscle, the palpebral fissure, the nasolabial fold, and the mouth, and observing at rest, in response to smile, in response to raise your eyebrows, and in response to close your eyes tightly. Weakness on the entire side of the face, where a patient is unable to wrinkle the brow, unable to close the eye, and has a flat nasolabial fold, is due to ipsilateral facial nerve or cranial nerve 7 palsy. Weakness of only the lower face with mild eye closure weakness and a flat nasolabial fold, but normal forehead wrinkling, is due to contralateral brain lesion.
Now let's assess hearing. And for the essential neurologic exam, we're just going to assess finger rub. So first of all, the patient has to have his eyes closed. And second of all, when you rub fingers on either side to see if he can hear it, don't touch his hair, because that will give him a sensory stimulus, a tactile stimulus. You don't want to do that. You want to only do a hearing stimulus. Close your eyes, sir, and tell me which side do you hear something?
Left. Right.
Are they the same both sides?
Yes.
Now this is a sensory testing, so you must ask, is it the same both sides? Now, some people would teach you to also do the Weber and Rene test, where you use a tuning fork and you assess it on the forehead or behind the ears. Those are excellent tests, but not in the essential neurologic exam. That is if someone has a symptom of hearing loss or hearing symptoms such as ringing the ears, tinnitus. Then you would do Weber and Rene. You don't have to do it on the essential neurologic exam.
Tips and pearls, cranial nerves, hearing. Make sure the patient's eyes are closed. Rub your fingers by each ear without touching the patient's hair. First ask if the patient hears each stimulus. Then ask, same both sides? Do not perform the Weber and Rene tests, both of which use a tuning fork, as part of the essential neurologic exam. Only perform them if the patient has symptoms of hearing loss or tinnitus. Unilateral hearing loss may be due to dysfunction of the ipsilateral vestibulocochlear nerve or cranial nerve 8.
Now let's assess the strength in the back of his throat by looking at palatal elevation. Now some people might use a gag reflex. I think that's not wise in an awake and alert person. There's a tremendous variability in gag reflexes among people, and it doesn't give us much information, and you run the risk of making someone very uncomfortable when you poke the back of their throat. So it's easier just to ask them to raise their palate by saying ah. That's why we say doctors say ah. Okay, open your mouth, and let's take a look, and you can say ah, and you can see the palate in the back goes up equally and symmetrically. That's normal, no need to use a tongue blade.
Tips and pearls, cranial nerves, palatal elevation. It is best not to use a tongue blade to assess gag reflex in awake patients for the following reasons. Both hyper and hypoactive gag reflexes are often normal, and therefore the gag reflex is rarely helpful in awake patients. The gag reflex is very uncomfortable for patients with hyperactive responses, and the gag reflex is most useful in assessing comatose patients. Instead, ask the patient to say ah and observe for symmetric palatal elevation. If necessary, use a light to illuminate the palate as demonstrated in this video on this slide. The palate is controlled by cranial nerves 9 and 10, glossopharyngeal and vagus nerves.
Now let's assess tongue strength. We're going to skip cranial nerve 11 now because 11 is actually lower in the body than 12, which is in the mouth. So we're going to do 12, cranial nerve 12, hypoglossal nerve, the tongue strength. And it's very simple. Sir, open your mouth and stick out your tongue. You want to see that it comes out directly in the middle, and then move it all the way to the left, all the way to the right. Perfect. Normal tongue strength.
Tips and pearls, cranial nerves, tongue strength. In patients with facial weakness, manually lift the upper lip when assessing tongue deviation. A flattened nasolabial fold may falsely make the tongue appear to deviate. Tongue deviation occurs due to ipsilateral tongue weakness, which in turn is usually due to ipsilateral hypoglossal nerve, cranial nerve 12, dysfunction.
Now let's assess cranial nerve 11, the head turn and shoulder shrug. So the head turn is the sternocleidomastoid. Sternocleidomastoid runs here in the anterior neck, and this is how you do this. You're going to have the patient turn all the way to the left, turn your head all the way to the left, and you're going to try, the sternocleidomastoid twists the neck, so you're going to pull on the chin. Don't pull on the whole head, underneath the chin. And because he may be unstable, you always want to put your other hand outside the arm so you don't push him over. So, sir, don't let me pull. And you can see that sternocleidomastoid contracting. Sir, now turn your head the other way, and I'm going to put my hand over here. Don't let me push. Don't let me push. Don't let me push. Good. Now, we're going to now do the trapezius. So, shrug your shoulders, sir. Shrug them. Don't let me push. Excellent. Now, there are only two muscle groups that you test at the same time, both sides. Trapezius, and later the deltoids, which we'll talk about later.
Tips and pearls, cranial nerves, head turn, and shoulder shrug. When assessing head turn, the sternocleidomastoid, ask the patient to turn the head in one direction. Stabilize the opposite shoulder, placing your hand outside, not on top, outside the patient's shoulder in order to avoid tipping over the patient. Ask the patient to resist your pull, and with your hand on the patient's chin, attempt to twist the patient's head to midline. When assessing shoulder shrug or trapezius, test both shoulders at the same time. Sternocleidomastoid and trapezius muscles are controlled by the spinal accessory nerve, cranial nerve 11. Note that the nucleus of the spinal accessory nerve is in the cervical spine. The nerve exits the cervical spine, enters the skull through the foramen magnum, then exits the skull through the jugular foramen before innervating the sternocleidomastoid and trapezius muscles.
Now let's test tone. You can test tone in the upper extremities and lower extremities. Now, the way to do it in the upper extremities, the best way, there are two ways, but one way is to take your hands, don't cross your hands, take your hands like this, and relax. Say, sir, relax, and do a quick jerk out, quick jerk out. And he's normal, but if he were not normal, it's called a spastic catch, where I do this and it goes slow and then catches. That would be increased tone, hyperreflexia is associated with that, etc. He has normal tone. Another way to do the upper extremities is shake your fingers real fast, like shaking the rings off. And you can see there's an equal speed to the shaking. That's the upper extremities. Now, the entire neurologic exam can be done seated or lying down. It doesn't matter, except for one thing, tone in the legs. So lie back down, sir. And I'm going to have to sit up for one moment. I'm going to put this down. Okay, lie down, sir. And we're going to pick up the leg. So what you want to do is totally relax, sir, totally relax. You want to let go, and the leg goes down. You'll pick it up a bit, and it slides on its own. Slides on its own. Good. Pick it up, just relax, and it comes slides down on its own. Slides on its own. Now, if he had increased tone, what would have happened is, when I picked up the leg, the heel would have come up first, and then it would have gone down. But that's not the case. He had normal tone, and the heel stayed on the bed the entire time.
Tips and pearls, motor, tone. Test tone in all four limbs. Test tone in the upper extremities via either assessing for spastic catch, grasping the backs of that patient's hands with your hands and quickly supinating, turning out your wrists. Or observe the patient shaking both hands rapidly to determine if one or both hands move slowly or stiffly. Test tone in the legs in the supine position. In the supine position, when the patient is in the supine position, lift the patient's knee, then drop it. If the patient is normal and relaxed, the heel will stay on the bed during both the ascent and descent, both the ascent and descent. Repeat on other side. Cortical spinal tract dysfunction, upper motor neuron lesion, usually causes increased tone and is associated with weakness, hyperreflexia, and a Babinski sign. Note that testing tone in the legs is the only part of the essential neurologic exam that requires the patient to be supine. One may perform all other components of the essential neurologic exam with the patient supine or seated.
Now let's assess pronator drift or arm drift. So put your arms in front of you, sir. You want to have the arm like holding a platter, palms up, and close your eyes, sir. And you want to watch for the hands. That's very good, sir. He's normal. If he were abnormal, weak a little bit in the arm, he would have had a little twisting. That's called pronation or drift down. Either one. Starts with pronation, then drift. That tells you there's weakness, a cortical spinal tract problem in the arm.
Tips and pearls, motor, arm drift. Test arm drift with the patient's eyes closed and palms up, like the patient is holding up a platter. Look for pronation or downward drift of an arm as a sign of weakness. If the patient is supine, realize that gravity may cause a weak arm to drift toward the patient's head. So when examining patients in bed, it is best to have their head elevated somewhat to improve assessment of arm drift.
Now let's test arm abduction through the deltoids. Sir, go like this, make chicken wings, good, and you want to push not too far out, not too far in. You're going to be right here on the knee, don't let me push. Normal deltoids, normal arm abduction. Now, this is the last time we're going to assess muscles at the same time, right and left. It's very important for all other muscle groups to go one side, then the other. But that's not the way it is for trapezius and deltoids, because otherwise you can tip the patient over.
Tips and pearls, motor, arm, abductors. Test both arms simultaneously, pressing down with your hands just medial to the patient's elbows. The deltoid muscles are the primary abductors of the arm.
Now let's assess elbow flexion or the biceps. So sir, go like this. Please realize when the hands are in this position, mid-position, it's actually assessing the biceps. This will be assessing the brachioradialis. This is biceps. This is brachioradialis. It doesn't matter which you test really, but in general, if you're consistent, stick biceps to biceps. So elbow flexion, and you want to hold, stabilize the joint you're testing. Stabilize the joint. And pull not above the hand, because that would be testing two joints, right? There's a wrist in the way. You want to be just below the wrist and say, don't let me pull. Good. And then you go to the other side. Stabilize joint, side to side. Stabilize the joint, don't let me pull. Excellent. That's biceps.
Tips and pearls, motor, elbow flexors. Stabilize the joint side to side. This is a very important tip for assessing most of the limb muscles. Stabilize a joint side to side. What is meant by that is when assessing the elbow flexors, for example, ask the patient to raise the arms in the flexed position, arms supinated, stabilize the elbow with your non-dominant hand, ask the patient to resist your pull, and then pull the arm just below the wrist with your dominant hand. After testing one side, immediately test the other side for comparison. Never assess biceps and then another muscle. Always assess one biceps to the other biceps, right to left or left to right. That's what we mean by side to side. And always stabilize the joint with your offhand. The biceps muscle flexes the elbow with the arms supinated. Note that the brachioradialis muscle flexes the elbow with the arms in mid-position between supination and pronation. Again, stabilize the joint with your non-dominant hand and test strength with your dominant hand.
For elbow extension or triceps testing, you put the hands in the exact same position as you did for biceps. Like this, sir, like you're putting up your dukes, as it were. Good. Now, instead of pulling, you're going to stabilize in the same place. You're going to push and assess the back of the arm here, the triceps. Don't only push. Strong. Don't only push. Strong. Normal triceps.
Tips and pearls, motor elbow extensors. Stabilize the joint side to side. When assessing the elbow extensors, ask the patient to raise arms in the flex position, arms supinated. Stabilize the elbow. Ask the patient to resist your push. Push the arm just below the wrist, just below the wrist. After testing one side, immediately test the other side for comparison. And again, stabilize the joint with your non-dominant hand and test the strength with your dominant hand. The triceps muscle extends the elbow.
Now let's assess wrist extension. Now, you might notice that we're not assessing wrist flexion in the essential neurologic exam. That's because the fingers only work in the wrist extended position. So the brain cares more about, has a lot more neurons for the wrist extension than wrist flexion, right? So we don't test wrist flexion. There's very few problems cause wrist flexion weakness. So we're not worried about that. And the essential exam, wrist extension. So go like this, like you're riding a motorcycle. Good. Now stabilize the joint. What joint are we testing? The wrist. So we're going to hold it at the wrist and then push. Don't only push. Good. Hold at the wrist. Stabilize joint. Side to side. Don't only push. Perfect. Normal wrist extension.
Tips and pearls, motor wrist extensors. Stabilize the joint side to side. When assessing the wrist extensors, ask the patient to raise the arms with wrist extended like you're riding a bike or a motorcycle. Stabilize the wrist with your non-dominant hand. Ask the patient to resist your push, then push down on the back of the hand with your dominant hand. After testing one side, immediately test the other side for comparison. The extensor carpi radialis muscle is the primary muscle that extends the wrist.
Now let's assess fine motor movements or finger tap. This assesses weakness in the fingers. So, sir, I want you to go like this. Take your fingers and go as wide as you can and fast, tap, 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 tap. Okay, you want to see width and you want to see speed. Normal width and speed, and you want to look at both at the same time to compare. If one were slower and smaller than the other, that's weakness, and that side is slower and smaller. But he had normal strength in the fingers.
Tips and pearls, motor finger tap. Have the patient tap the index fingers and thumbs together in both hands simultaneously as wide and fast as possible, and look for differences. Small or slow excursions suggest weakness in the hand. This test substitutes for testing grip strength, which has poor inter and intra-rater reliability.
Now let's assess strength in the legs. Now when a patient is in bed here, we want to have the patient stabilize himself on the side of the bed, okay? And you want to say, lift, we're now assessing hip flexion. And to do that, say, lift your leg. Lift it up, sir. Don't only push. Good. Now the other one. Don't only push. Now if he were seated, it'd be a different direction. You wouldn't say lift your leg, you'd say lift your knee. If he's seated, lift your knee, right? But in the bed, it's lift your leg, and it's same both sides.
Tips and pearls, motor hip flexors. Ask the supine patient to lift one leg. Then push down against resistance with your dominant hand. Then do the other side. Ask the seated patient, however, to place both hands on the side of a chair for stability and lift one knee, as shown in the video below. Push down against resistance, again, with your dominant hand.
Stabilize yourself. Always have him stabilize himself first. And then you say lift your knee. Remember the hip flexors were lift your leg. Now it's lift your knee. Lift your knee, don't only push. Good. The other one, don't only push. Good. Now let's do knee extension or the quadriceps. So we're going to have the patient straighten his leg out a bit, not completely, just partially bent, and hold it under your hand underneath. You're stabilizing underneath now. And then you push at the top of the ankle here. Don't only push. I'm testing that quadriceps muscle. Right there. Knee extension. Don't only rest it gently, and then don't only push. Good, I'm pushing on the outside. Remember that hamstrings was back here, and like this. Quadriceps is like this.
Tips and pearls, motor, knee extensors. Stabilize the joint side to side. When assessing the knee extensors, stabilize the knee. Place your hand or arm, the non-dominant hand or arm, under the patient's knee and elevate the partially flexed leg. Ask the patient to resist your push. Then with your dominant hand, push the leg just above the ankle. After testing one side, immediately test the other side for comparison. The quadriceps muscles extend the knee.
Now let's assess the knee flexion or hamstrings. So we're going to say to the patient, bend your leg like this, right? And you stabilize the joint. So what are you doing? You're pushing. So I'm stabilizing his femur, right? And I'm testing the hamstrings by pulling here at the back of the Achilles, And I stabilize by pushing inward like this. Do not let me pull. Don't let me pull. Normal hamstring. Let's see this one. Do not let me pull. Normal knee flexion or hamstrings.
Tips and pearls, motor, knee flexors. Stabilize the joint side to side. When assessing the knee flexors, ask the patient to elevate a leg in the flexed position. Stabilize the knee by placing your non-dominant hand on the patient's kneecap and push inward towards the patient's hip to stabilize the femur. Ask the patient to resist your pull. Then, using your dominant hand, pull the leg at the ankle, at the Achilles tendon. After testing one side, immediately test the other side for comparison. The hamstring muscles flex the knee.
Now we're going to test the strength in his ankle, okay? So we're going to test both dorsiflexion and plantar flexion. Start with dorsiflexion. Put your toes all the way back, sir, and you stabilize at the joint, ankle, and you pull. Don't only pull. Excellent. Then your other side. Don't only pull. Now remember, once again, even though it seems more convenient, don't pull together. If you pull at the same time, you're testing multiple muscles, and you're not isolating the muscles you want to test. It's always stabilize the joint, side to side.
Tips and pearls, motor, ankle dorsiflexors. Stabilize the joint, side to side. When assessing the ankle dorsiflexors, stabilize the ankle using your non-dominant hand. Ask the patient to point toes back toward your head and resist your push. Then, using your dominant hand, push the back of the foot. After testing one side, immediately test the other side for comparison. The anterior tibialis muscle dorsiflexes the ankle.
Now let's do ankle plantar flexion, putting the feet down. Put your foot down here, sir, the right foot, and stabilize at the joint, and don't only push. Good. Put your foot down on the left, don't only push. Good. Normal strength throughout the lower extremities.
Tips and pearls, motor, ankle plantar flexors. Stabilize the joint side to side. When assessing the ankle plantar flexors, using your non-dominant hand, stabilize the ankle. Ask the patient to point the toes down, like pushing down on the gas pedal or accelerator, and resist your push. Then, using your dominant hand, push the ball of the foot up. After testing one side, immediately test the other side for comparison. The gastrocnemius muscle plantar flexes the ankle.
Now we'll do sensation on the body. Now, in this training video, we're separating the facial sensation from the body sensation. In fact, you might want to do all together in real life because you already have your safety pin out, for example, and you're already giving instructions. So let's go through it now, body sensation. And we want to test in the body the backs of the hands and or even the fingers. More distal the better. And the backs of the feet or toes. The more distal the better. Why? Because most conditions in neurology will affect distal more than proximal sensory loss. So if patients have normal distal sensation, you don't have to worry about the proximal. And it's really important not to over-test in sensation. You don't want to say, where am I? Just stick to 4 basic areas when you're doing the essential exam. But backs of the fingers, backs of the toes. So let's start with light touch. And once again, You ask with light touch, where am I touching you? And you go very light little brush. Close your eyes, sir. Where am I touching you?
Left hand, right hand.
Are they the same both sides?
Yes.
You have to ask that, or you didn't do the sensory exam, because you can have a relative sensory loss, right? You might have partial sensory loss on one side and not tell you, well, I feel it, but is it the same? You have to ask, is it the same both sides? Now let's do the toes. Where am I touching you?
Right toe, left toe.
Same both sides?
Yes.
Tips and pearls, sensation, light touch. When assessing sensation in the limbs on the essential neurologic exam, test the back of a finger on each hand and the back of a toe on each foot. Don't waste time with superfluous testing. Keep the patient's limbs uncrossed and eyes closed. Do not touch the patient elsewhere when testing sensation. For example, don't give a comforting pat on the shoulder somewhere else. Just touch the patient only where you're assessing sensation. When testing light touch, lightly stroke the skin. Do not tap. Lightly stroke. And ask, where do you feel it? In the essential neurologic exam, after similar stimuli on each side, always ask, same both sides? Remember that all sensory testing involves comparing two different areas. For example, right versus left, or distal versus proximal. For simplicity's sake, in the essential neurologic exam training, we assume we are looking for brain dysfunction and comparing only left to right.
Now let's do the pinprick again. And one thing I neglected to tell you when we did the facial sensation with pin is how you do the pin. In general, we have much more control of our wrists than our whole hand. And I would urge you not to push with the pin with your arm, but rather do taps with the wrist. Keep it all on the wrist. And I urge you to use 2 taps. Sometimes when you do only 1 tap, you don't hit them the same way both times. 3 or 4 taps, they start losing the sensation. So you want to do a couple taps. So let's do this. Sir, is this sharp or dull?
Sharp.
Sharp or dull?
Sharp.
Double tap using the wrist. Let's now go to the back of the fingers, back to the toes. Sharp or dull?
Sharp. Sharp.
Same both sides?
Yes.
I neglected to ask you up here. Is it same both sides in the hands? Let's do this again.
Sharp. Sharp.
Same both sides?
Yes.
Now if you forget to say same both sides, just go back and do it again and ask same both sides. You have to always ask that question.
Tips and pearls, sensation, pinprick. When assessing sensation in the limbs on the essential neurologic exam, test the back of a finger on each hand and the back of a toe on each foot. Don't waste time with superfluous testing. Limit testing to the 4 areas and limit the number of dull stimuli. Keep the patient's limbs uncrossed and eyes closed. Do not touch the patient elsewhere when testing sensation. When using a pinprick, using your wrist, tap twice firmly with a safety pin. Ask, is it sharp or dull? In the essential neurologic exam, after similar stimuli on each side, we always ask, same both sides? Because all sensory testing involves comparing 2 different areas. For example, right versus left or distal versus proximal. For simplicity's sake, in the essential neurologic exam training, we assume we are looking for brain dysfunction and comparing left and right. Don't forget, always discard the safety pin in a sharps box after use. Never reuse a safety pin on another person.
Now let's assess vibration over the body, okay? And the way to do that, first of all, use a 128 tuning fork, 128 hertz. That's the bigger one. The smaller ones, 256 hertz, are actually not adequate. Even though they're more convenient to put in your pocket, they're not adequate for sensation because some normal people can't feel that high-pitched 256 hertz. So 128 hertz, first of all. And what we're going to do is we're going to hit the top of the tuning fork and hold at the bottom. Don't hold the arms because that'll dampen it yourself. Hold it, and you put this over a bony prominence. All vibration is felt over a bony prominence. Now, a couple other important points. Number 1, never let the patient cross his arms or legs. People with abnormal cognition will sometimes get confused which side you're touching. So in a neuro, we have a lot of people with abnormal cognition. So keep the arms and legs separated, first of all. Second of all, you're going to go as distal as possible on a joint, okay? I want to point something else out. Sometimes you'll see folks telling you use a lot of negative stimuli to see if they're telling the truth. I don't do that very often, maybe once in a blue moon. The important thing is, if you do that, don't forget to go back and do the positive stimulus, because the important thing is, can they feel the positive stimulus? That's what we care about. So let's do the vibration. Close your eyes, sir. Close your eyes. And you feel that buzz?
Yes.
And that's the question you ask. Do you feel the buzz? Don't say do you feel it, because they can feel touch. That's not what we're testing here. We're testing vibration. So do you feel the buzz of the vibration? Once again, do you feel the buzz? You feel the buzz, sir?
Yes.
You feel the buzz?
Yes.
Are they the same on both sides?
Yes.
Now notice that I did not stop the buzz in between. You can do that if you want, but it's easier and I think more accurate if you use the same buzz twice quickly. That way the stimulus is the same and it's more accurate. Let's try the toes. You feel a buzz, sir?
Yes.
Do you feel a buzz?
Yes.
Are they the same on both sides?
Yes.
Good, normal vibratory sensation.
Tips and pearls: sensation, vibration. When assessing sensation in the limbs on the essential neurologic exam, always test the back of a finger in each hand and the back of a toe on each foot. Don't waste time with superfluous testing. Keep the patient's limbs uncrossed and eyes closed, and do not touch the patient elsewhere when testing sensation. When testing vibration, hold the tuning fork handle and strike the tines. Place the end of the handle on a finger or toe joint. Ask, do you feel a buzz or vibration? Do not ask, do you feel it? Say specifically, do you feel a buzz or vibration? In the essential neurologic exam, after similar stimuli on each side, always ask, same both sides. Same both sides. Because all sensory testing involves comparing two different areas. For example, right versus left or distal versus proximal. And for simplicity's sake, in our training today, essential neurologic exam training, assume we are looking for brain dysfunction comparing left and right.
Now we're going to assess proprioception or joint position sense. And we're going to want to do this as distally as possible in the fingers and toes. And this technique is complicated, so listen carefully. First of all, show the patient what you're doing, and you're going to hold in the distal joint, and make sure the fingers are oriented such that there's up and down this way. And you say to the patient, you hold on the side, you say to the patient, don't you move the fingers, only let me move the fingers. And you hold on the side, everybody. Don't hide. If you go like this, you're giving pressure sensation up and down. You don't want that. Hold on the side, distal, and say, okay, sir, close your eyes and tell me which direction this is, up or down.
Down.
And notice I'm moving just a millimeter.
Up. Down.
At least 3 times would be the most to get to the best information. Now, same thing on the other side, sir. Eyes closed. Which way am I moving your finger?
Down. Up.
See that a normal person can sense slow 1 millimeter movements. That's what you want. Let's go to the toes now, sir. Keep your eyes closed, sir, and stabilize distally. Which way am I moving your toe?
Down. Up.
Good. 3 times. Which way am I moving your toe?
Down. Up.
Good. Normal proprioception.
Tips and pearls: sensation, proprioception. First, when assessing proprioception, demonstrate the process to the patient with the eyes open, and then ask the patient to close their eyes for testing. Hold and stabilize the sides of the distal-most joint of a digit with one hand, and hold the sides, once again the sides, of the digit distal to that joint with your other hand. Tell the patient not to move the digit, but to let you move it. Move the digit very slowly and very slightly, only a millimeter, up or down, and ask, up or down. Repeat 3 times per digit. Test the distal joint of one digit on each limb. Proprioception is also known as joint position sense, or JPS. The same nerve fibers carry joint position sense and vibration sensation.
We will now assess reflexes. Now, to assess reflexes, you obviously need a reflex hammer. I would urge you not to buy a light little hammer. You want a heavy-headed hammer so you get torque. And you'll see in a moment, I just talked a moment ago when using pinprick, that your arm is not as effective as your wrist. And in general, with reflex, you want to use wrist. So some principles: wrist, not arm. And to use a wrist, you have to have a heavier head. The lighter head ones are really, you can't get enough energy. You have to really throw your arm behind it. That will not give you equal good reflexes. So heavy-headed reflex hammer. This one's called a Tromner hammer with a good heavy head, number 1. Number 2, the reflexes are like a guitar string or a drum. You want to pluck them. You want to come off them. If you stay down on it, you deaden the guitar string or drum, right? So when you're doing reflexes, you want to whack it and come off. whack it, and come off. Now, in some reflexes, you'll see we'll be putting our fingers over the reflex for certain reasons. Other times, you just hit the reflex itself. Let's start with the biceps. So the biceps reflexes are here. Now, one of the mistakes I see people make all the time is the patient goes like this. Don't do that. You want to keep the palms down, and very important in almost all reflexes to keep the arms at a 90-degree angle as much as possible. 90 degrees, not extended. 90 degrees, palms down. Now, the problem with the biceps is it's hidden in the crease of the elbow. So you have to put your thumb in there so you can feel it. And you feel this little rope, and then you whack it. You whack your thumb. See that? You can see the biceps jerk. Now, on the other side, I put my hand on the other side, and I let his hand feel heavy on my arm. So I want his arm relaxed. And if it's heavy on the arm, then I know that it's in a relaxed position. Then I whack my thumb. There it is. See that? That's the biceps jerk.
Tips and pearls, reflexes, biceps. When assessing reflexes in general, keep the patient relaxed and the joint at 90 degrees. Use a good reflex hammer that has a heavy head or is long. Use your wrist as much as possible. Give the reflex a firm strike, a quick strike. I say give it a whack, firmly and quickly. Come off the tendon quickly. Do not allow the reflex hammer to linger on the tendon. Do not dampen the guitar string. For the biceps reflex in particular, keep the patient's arms flexed at 90 degrees with the palms down. Feel the biceps tendon in the antecubital fossa with your thumb. Keep your thumb on that tendon, and then strike your thumb firmly and quickly. C5-6 nerve roots supply the biceps reflex.
Now let's assess the brachioradialis. Now brachioradialis, like the biceps, is C5-6, similar roots, by the way. The brachioradialis is an interesting tendon. It comes from the thumb and crosses over this way to the brachioradialis, right? On a diagonal. So because it's a diagonal, you actually want to put your fingers, here's the problem. If you hit the actual tendon itself, there's bone under there and it hurts the patient. So in this case, you need to put your fingers in the way. But here's the important point, not press. If you press, you dampen the guitar string, right? So keep it at a right angle, and you want to put your fingers at an oblique angle, not on the back dorsum, not on the side, but this oblique angle, and you don't hardly touch them, but you whack it. And you get a brachioradialis reflex. Like this. I might come over on this angle, and whack it. And you see the brachioradialis reflex.
Tips and pearls, reflexes, brachioradialis. Again, when assessing reflexes in general, keep the patient relaxed and joint at 90 degrees. Use a good reflex hammer with a heavy head or a long stem. Use your wrist as much as possible, not your whole hand, whole arm, just the wrist. And give the reflex a whack. Give it a whack. Hit firmly and quickly. Come off the tendon quickly. Do not allow reflex hammer to linger on the tendon, so don't dampen the guitar string. For the brachioradialis reflex in particular, keep the patient's arms flexed at 90 degrees with palms down, the same position as for the biceps. But this time, place your fingers over the tendon just above the wrist at an oblique angle to the arm and barely touch the patient with those fingers. Barely touch the patient. And then strike your fingers firmly and quickly. C5-6 nerve roots supply brachioradialis reflex just like to supply the biceps reflex.
Now to the triceps reflex. Now, a lot of folks will teach you to put the arm up in the air. I don't like that technique because the arm up in the air, you end up putting a lot of tone in the arm, and again, to get good reflexes, the arm has to be relaxed. So the best thing to do, for my opinion, is just keep it in the bed, palm down, and you hold the elbow up. You hold it so you can feel the heaviness, so he can totally tell he's relaxed. Keep the arms relaxed on him, and you're going to come behind, and the place you want to hit is at the very bottom, this little soft pad. It's like in the patella in the knee. It's a similar concept because the extensor of the arm and the patella is the extensor of the leg. So it's just above the bone, rest above the bone, and you don't put your finger in the way, and you hit it. And you see a triceps reflex. Okay? Going to the other side, I will now keep him, just like I did with the biceps, resting on my arm, and I'm going to hit right there. Remember, the bone is here. You don't want to hit in the muscle. You want to hit in the tendon, which is right there, the soft pad just above the bone, and you want to whack it. And if he's not relaxed, relax, Try it again. There. See how I relaxed him and the reflex was better.
Tips and pearls, reflexes, triceps. So once again, when assessing any reflex, keep the patient relaxed and the joint at 90 degrees. Use a good reflex hammer that's got a heavy head or a long stem. Use your wrist as much as possible. Give the reflex a whack, hit firmly and quickly, come off the tendon quickly. Do not allow your reflex hammer to linger on the tendon. Don't dampen the guitar string. Now, for the triceps reflex, once again, you keep the patient's arms flexed at 90 degrees with the palms down and arms full relaxed. Exact same position as you had for biceps and brachioradialis. Locate the triceps tendon, that soft spot just above the elbow, on the back of the arm there. And then strike that tendon. Do not put your fingers in the way on the triceps. Strike the tendon firmly and quickly. C7, 8 nerve roots supply the triceps reflex.
Now let's do the reflexes in the legs, the two main places, the knees and the ankles. So we'll do the knee jerk or patellar reflex. And you need to have the leg at a right angle. So you want to lift the leg up and feel it heavy again. And that soft pad right below the kneecap. And there's the knee reflex, or patellar reflex. Do the other side now. Lift it up, 90-degree angle. And you want to not hit the cap, not hit the bone in between the soft pad. There you go, patella.
Tips and pearls, reflexes, patella or knee jerk. When assessing reflexes, once again, keep the patient relaxed and joint at 90 degrees. Use a good reflex hammer. Use your wrist. Give it a whack and come off the tendon quickly. For the patella or knee reflex, keep the patient's knee at 90 degrees and relaxed with the lower leg dangling down. Strike the patellar tendon, that soft spot just under the kneecap, under the patella, firmly and quickly. L3-4 nerve roots supply the patella reflex.
Now let's assess the ankle jerk or Achilles reflex. A couple different ways to do this. An easy way, in my opinion, is just you want to relax the foot, because often people have like a tone in their foot. You want to relax, and then you want to hit that Achilles tendon. You want to whack it and lift it up. You want to lift it up, and just when you lift it up, then you hit it. And you see how he plantar flexes his foot when I do that. All right? Let's do the other side. Relax and hit, and you see the reflex. Now, a lot of people have trouble with this reflex for some reason. They want to do all kind of crazy things. Now, one thing you could do if you wanted to is cross it over, and it makes it a little easier sometimes to do. You can do that. When they're sitting, you can do other things. Some people can, want to make all the tone better, so they go like, do this, patient. Those are possible, but honestly, if you relax the patient, you do that little wiggle I said, and then put it up, and as soon as it goes up, you hit it. You almost always get a good ankle reflex.
Tips and pearls, reflexes, Achilles or ankle reflex. When assessing reflexes, once again, keep the patient relaxed and joint at 90 degrees. Use a good reflex hammer, use your wrist, give it a whack, and come off the tendon quickly. For the Achilles or ankle reflex, wiggle the patient's foot slightly just to relax it. Then gently pull it up, gently and quickly. Pull the foot up, that is to say dorsiflex it, and immediately strike the Achilles tendon firmly and quickly before the patient has time to contract a leg muscle. S1-2 nerve roots supply the Achilles reflex.
The last thing we're going to test for reflexes is the Babinski sign. Babinski sign. And what is that? That is when you scratch the bottom of the foot and see if the toe goes up. Now, sometimes the toes fan and all the toes go up, but the most important thing is that big toe. So we're going to do the left side first, and I want to show you where we're going to go. We're going to go on the lateral here and curve over. Okay, here we go. And boom. And the toe, in this case, is going down. See how it went down a little bit when I scratched a little harder? And then the other side, same thing. Look at the big toe, and when I do this and curve over, the toe goes down a little bit. That is an absent Babinski sign. You don't call Babinski signs positive and negative. They're absent or present. So if it's present, the toe would go up. If it's absent, the toe goes down. And sometimes it's called equivocal when it doesn't move at all.
Tips and pearls, reflexes, Babinski sign. When performing Babinski testing, use a firm, non-sharp object, such as the handle of a reflex hammer or tuning fork, to stroke the patient's sole. Stroke firmly, but not too hard. Stroke the lateral aspect of the sole, beginning near the heel and crossing over the ball of the foot, as demonstrated in the cartoon on this slide. A Babinski sign is present if the big toe dorsiflexes upward. It's absent if big toe plantar flexes, that is, moves downward. and the Babinski sign is equivocal if the big toe doesn't move at all. Cortical spinal tract dysfunction, that is to say an upper motor neuron lesion, causes Babinski sign along with hyperreflexia, weakness, and increased tone.
Now let's assess coordination in the upper extremities and lower extremities. That's finger to nose testing and heel to shin testing. So let's understand what the cerebellum does. The cerebellum in the back of the brain, underneath the brain and behind the brain stem, is the coordination center. It makes sure that the agonist muscles and the antagonist muscles are coordinated, that they're speaking to each other. For example, if you want to contract your biceps, the agonist muscle, you need to make sure the antagonist muscle, the triceps, is not contracting. And that's what the cerebellum does. It makes sure that one is relaxing while the other one's contracting. Okay? Now, if the cerebellum is not working, if there is a problem with the cerebellum, then there's a dyscoordination or a dys coordination, abnormal coordination, or an abnormal ataxia, dystaxia. Taxia is coordination. So that patient then has what looks like a tremor. So we often call that an intention tremor because it happens when you're trying to use the arm, but really it should be better described as an ataxia or dystaxia of a limb. Now, when you're assessing ataxia or coordination, you're assessing a couple things. Smoothness of movements, that's the coordinations part, and do they hit their target? It takes more coordination to go at the end to hit your target. So you want to look, and that's called metria. So when it's abnormal, it's called dysmetria. So you're looking for dystaxia and dysmetria, not hitting the target. Okay, let's start with finger to nose. And the eyes are open, and you say, sir, touch my finger with one finger. Touch your nose with the same finger. Go back and forth as fast as you can. And pull out a little bit, stretch it a little bit, and you can see that he stays accurate. Now the other side, sir. Beautiful. And he touches it accurately.
Tips and pearls, coordination, finger to nose. Always observe both dysmetria and dystaxia when assessing coordination. Dysmetria is inaccuracy or missing the target, and dystaxia is uncoordinated or choppy movements, also known as an intention tremor. Assessing speed is not as important. Coordination is considered normal if a limb is weak and moves slowly yet smoothly and accurately. You're looking for smoothness and accuracy. Abnormal coordination of a limb, known as ataxia or dystaxia, is often due to dysfunction of the ipsilateral cerebellar hemisphere or pathways. The cerebellum facilitates communication of agonist and antagonist muscles, ensuring the antagonist muscles do not contract when one wishes to use an agonist muscle. Dysmetria and dystaxia are a result of concurrently contracting agonist and antagonist muscles. On finger-to-nose testing, detect subtle ataxia by fully extending the patient's arm.
Now let's assess coordination in the lower extremities. That will be heel to shin testing. So put your legs straight, sir, for me. Okay. Now, this is a confusing command, so it's best to show the patient. With your heel, sir, let me do this for a second. I'm going to take your heel, and I want you to put it up in the air, and then down on your knee, and then run it down the shin. Okay? Up and back once like that. Okay? And then we'll do the other side. You ready? Okay, now, with this to heel, touch up in the air, heel and knee, run it down the shin. And you see it's smooth and hits the target. Okay? Put it down. Now the other leg, up in the air, now on the knee, and look, it hit the knee perfectly, and then it went down smoothly on the target. Normal heel to shin testing, normal cerebellar dysfunction, normal coordination in the legs.
Tips and pearls, coordination, heel to shin. Once again, observe both dysmetria, inaccuracy or missing the target, and dystaxia, uncoordinated choppy movements or intention tremor. Abnormal coordination of a limb or ataxia, dystaxia is often due to dysfunction of the ipsilateral cerebellar hemisphere pathways, and the cerebellum facilitates communication of agonist and antagonist muscles, ensuring that antagonist muscles do not contract when one wishes to use an agonist muscle. Dysmetria and dystaxia are a result of concurrently contracting agonist and antagonist muscles. On heel to shin testing, detect subtle ataxia by first observing for dysmetria. Ensure the heel hits the knee before you assess the motion of the leg moving down the other leg. Please note something as displayed in this video on this slide. In a seated patient, Have a patient stabilize himself by holding onto the chair on either side or holding onto the arms of a chair. And then you lift the leg you are not testing so that it is parallel to the ground. This prevents the tested leg from simply falling due to gravity. And then have them do the heel to shin. And then do the other side, as again displayed in this video.
Now let's assess gait and station. So first of all, let's have the patient, help the patient off the bed. Come over here, sir. Swing around. There's a stool here. Get down. Thank you. Stay near the patient. Walk over here, sir. Stay near the patient in case he has problems. Okay, stand right there, sir. Now, I want you to walk normally from there to there and come back a couple times. Okay, turn around. Stay near the patient in case he has normal gait. Now stop 1 second, sir. What we're looking for in gait is the size of the steps. Do they outdo each other? In abnormal gait, small steps would be not exceeding each other. He has exceeded each other, first of all. Second of all, we're looking for the base. So there's really no such thing as too narrow base. Normal people cross over a little bit. If you'll notice, when I walk with my legs straight, it looks weird because that's not how we walk. We walk with our legs crossed over a little bit, right? And so they're looking at narrowness. If it's wide, a wide base often means a cerebellar problem, a coordination problem. Truncal ataxia is associated with that. The other thing you're looking for is arm swing. So the arms move together because like a normal person. So if one arm is not moving, then one of two things is happening. Either they're weak in that arm or they have Parkinson's syndrome. Parkinson's disease leads to rigidity and less arm movement, and weakness leads to less arm movement. So you're looking at arm swing. And you're looking at posture. Is he bent over or is he standing straight? So posture, width of the base, size of the steps, and arm swing. Let's do that again. Walk normally, and you see the normal, everything's normal. Posture, the base, walk back, sir, the steps of are normal size, etc. Excellent.
Tips and pearls, gait and station, regular gait. Do not test gait in socks on a hard floor. Socks are too slippery and put the patient at risk for falling and even head trauma. Shoes or bare feet are actually preferred. Always stay near the patient when assessing gait in case the patient has imbalance or falls. And during assessment of regular gait, observe 4 things: step size, base width, arm swing, and posture. Parkinsonism is associated with small steps, decreased arm swing, and stooped posture. Cerebellar dysfunction, especially midline cerebellum or vermis dysfunction, is associated with wide-base gait, and arm weakness is associated with decreased arm swing.
Now we're going to assess toe and heel walking. So we already assessed gastrocnemius, plantar flexion, and intertibialis dorsiflexion in the ankle. But those are such strong muscles that sometimes normal people can seem normal on test, but then they have trouble walking. So we're going to do test those muscles again by toe and heel walking. So it's best to start by, if you're going to be behind the patient a little bit, you can see the heel up. So sir, get up on your tippy toes and walk tippy toe across. And stay near him again. Good, turn around and walk on your toes. And he elevates the heels equally on both sides and has no problem. Now let's do heel walking, now testing anterior tibs. Sir, get up on your heels and walk across the room there. Good, turn around and walk on your heels. And you see the toes are elevated, ball of foot is elevated. It's normal, equal, and symmetric. Normal toe and heel walking.
Tips and pearls, gait and station, toe and heel walking. Once again, do not test gait in socks on a hard floor. Always stay near the patient when assessing gait. Toe walking tests strength of gastrocnemius muscles, the ankle plantar flexors, and heel walking tests strength of intertibialis muscles or ankle dorsiflexors.
Now let's assess tandem gait, which assesses truncal ataxia, or the middle of the cerebellum or vermis. Come over here, sir. Okay, I want you to do this for me. I want you to touch toe to heel in a straight line like you're on a tightrope, okay? Good, and stay near the patient, because these folks, if they have problems with this, they're going to fall because it's an ataxia problem.
Tips and pearls, gait and station, tandem gait. Do not test gait in socks on hard floor, and always stay near the patient when assessing gait. Tandem gait tests the cerebellum. Cerebellar vermis, or middle of the cerebellum, or pancerebellar lesions cause wide-based, unsteady, regular gait and difficulty performing tandem gait. Cerebellar hemisphere or pathway lesions cause patients to veer or fall to the ipsilateral side, both in regular gait and tandem gait.
The last thing we're going to assess is the Romberg test. Now, the Romberg test, it tests actually proprioception. A lot of people think it tests cerebellum. It doesn't. So let's explain something. The cerebellum has 3 sensory inputs: vision, vestibular, and proprioception, position sense. In order for the cerebellum to work, it has to have 2 out of 3 of those sensory inputs. Okay? Vestibular, proprioception, vision. Now, if I ask him to put your feet together, I gotta stand with my arms right here, but ready to catch him in case he wobbles, and you look for his eyes open. Now, if he wobbles with his eyes open, you don't say the Romberg test was positive. You say, we cannot test Romberg test because the patient wobbling with the eyes open cannot test. The Romberg is specifically with the eyes closed. So let's watch. Close your eyes, and I'm ready to catch him, but he's not moving. He's fine. Don't push the patient, just watch him and be ready to catch him. Open your eyes, sir. So here's the point. By eliminating the vision, all he has left is vestibular and proprioception. They must both be intact. If he had proprioception out or vestibular out, either one, he would have been wobbly. The vast majority of cases, when you're testing Romberg, you're really testing the proprioception in the feet. If there are things like diabetic peripheral neuropathies or spinal cord problem, etc., because if you have a vestibular problem, you usually feel dizzy, vertigo, etc., and you know it's a vestibular problem. So most of the time, you're testing proprioception when testing the Romberg test.
Tips and pearls: gait and station Romberg test. Once again, do not test gait and station in socks on a hard floor, and always stay near the patient when assessing any aspect of gait and station, including Romberg test. For Romberg testing, ask the patient to stand with legs together and then observe if the patient is unsteady or falls with eyes open. If so, do not proceed further, and then document that Romberg was actually untestable because the patient fell with eyes open. If the patient is steady with the eyes open, then you may ask the patient to close the eyes, but be ready to catch the patient if necessary. Have your arms around the patient without touching the patient, ready to catch the patient in the event they fall when the eyes are closed. The Romberg test is considered positive if the patient is unsteady or falls with feet together and eyes closed. You cannot assess the Romberg test with the eyes open. If the patient falls with eyes open, you can't test Romberg. You simply say, not testable. If the Romberg test is only positive if the patient is unsteady or falls with the feet together and eyes closed. And it signifies something wrong with proprioception or vestibular apparatus. So let's make this very clear. The Romberg test does not assess the cerebellum. It assesses the sensory input to the cerebellum. And when there are 3 sensory inputs, you need 2 out of 3. You close your eyes, you have only left proprioception and vestibular apparatus. If you fall with eyes closed on Romberg test, then you have something wrong with proprioception or vestibular apparatus. And please never push or pull a patient when testing Romberg. In fact, you don't touch them at all unless they are about to fall and you catch them. After viewing this presentation, you should be able to accomplish the stated learning objectives reproduced on this slide for your review. This is the end of this presentation, a production of DLGINSITE, innovative neuroscience ideas and thoughts on education.